Madam Mahatme is also joined.
Yes, we are live. We can start.
Guys. Okay, good evening. Welcome to all of you on behalf of IMA Tiswadi. I welcome all of you for this nice panel discussion that has been set up with good faculties, and I would like to thank each one of you. And Amol is going to, be the orchestra guy to monitor all the proceedings. So Amol, please take over, and wish you guys happy listening.
Thank you, Dr. Mahendra. Can I request Rohan to mute everybody and so that we'd have less disturbance? Yeah, so today is 25th April and it's the World Malaria Day. And at IMA Tiswadi, we are having this symposium, online webinar with a galaxy of experts to try and understand malaria. Malaria is a disease that has been there for centuries, as old as mankind. In fact, one of the beautiful lines by William Osler in the textbook of medicine is that man has but three enemies: fever, famine, fever, war, and famine. And by far, fever is the one that has killed many more than anybody else. And of all fevers, I think malaria is one of those that has killed the maximum number of humankind. Another interesting tidbit that you would like to know is that the Nobel Prize was awarded to Ronald Ross, who's actually a British physician in Indian Medical Service, having done most of his work in Secunderabad. He was interestingly the first non-European, means somebody born outside Europe, to win the Nobel Prize. The other distinction of a non-European also goes to India in the form of Rabindranath Tagore in 1911. But Ronald Ross was awarded in 1902. So with this, very interesting tidbits, we'll straight away dive into the topic, which is malaria. Malaria has been causing a lot of deaths across the globe. India has particularly been suffering a large number. It's said that outside of Africa, India is one country that gets affected by the maximum number of people from malaria. Credit to the health services in India and especially in Goa, we are now in a phase of elimination of malaria. A few years back, Dr. Amit would agree with me that in the early 2000s, late 1999, in the 90s, late 90s, it was practically impossible to think that we would ever get over the huge wave of malaria. We used to see so many hundreds of people getting malaria, and quite a few deaths, especially cerebral malaria, pediatric cases. So in lieu of that, today we have this galaxy of experts, and let me start by introducing Dr. Amit Dias, who's an epidemiologist par excellence. He's somebody who has done his MBBS and MD from Goa Medical College, a highly awarded scholar. He's widely traveled. His research papers in non-communicable disease, especially in dementia, have won him a wide critical acclaim. He also continues to teach at the Goa Medical College, and in his part-time and when he's allowed to, tries to educate the public. That smirk, he and I know what it means. But let's just dive into the topic of malaria, and we'll understand from Amit what is the epidemiology, how it starts. Because malaria is not just about the mosquito that you see behind me. Actually, there is something inside the mosquito. And Ronald Ross has very beautifully penned. Besides being a scholar, he was also a poet. He says, "With tears and toiling breath, I have discovered thy cunning seed, O murderer of million deaths." I hope I got that right. Amit will tell us more. Over to you, Amit. Please unmute yourself, Amit. Rohan, I think you have to unmute Amit. Yeah.
Yeah. Thanks, Dr. Amol, for that wonderful introduction to this topic of malaria. And thanks for this invitation. It's very strange that in April, in this hot summer, when you don't think there will be cases of malaria, that we are actually observing Malaria Day. But the whole idea is to prepare ourselves for the things to come. So usually we see a spurt of malaria cases in the month of June in the monsoons. But we need to prepare that. And the whole idea is about focusing on prevention And the theme this year is about innovation. It's about trying to do something different because we have been doing quite well. In fact, when you listen to this lecture, you'll understand our achievements as far as malaria is concerned. But we also learn from our history that we should not be complacent. When we were complacent in the past, malaria made a comeback. And we have to understand that this can happen again and we should not let it happen. So keeping that in mind, let us kind of just run through certain things about the epidemiology of malaria, where we talk about the agent, the host, and the environmental factors that affect malaria. As Dr. Amol said, malaria was a disease that is known for long. From even Hippocrates has actually written about malaria, but they talked about malaria as malaria. It's Latin to say there is bad air or evil in the air that is causing malaria. That's how it gets its name. I put this picture up of some Roman soldiers because Roman soldiers were told if you put a camp anywhere, if you put a tent anywhere, make sure it is not close to a swamp because there are some fumes that come out from these swamps that can cause this disease, that can cause fever, and you can die of this fever. This malaria that occurs from the fumes that come from the swamp. And not many people knew what was causing it, but it was taking a lot of lives. A lot of people were dying because of this disease, but they didn't know what was really causing it. And as Amol really pointed this really well, Sir Ronald Ross in Secunderabad, who did a lot of studies, dissected mosquitoes and found that the parasite was existing in that and tried to put two and two together because before that, Charles Leveran had already identified the malaria parasite, but he didn't know how it goes from one person to the other. That was kind of not known. When Ronald Ross did some very interesting experiments, it's worth knowing all those, reading a little more about those experiments that he did, how to prove how these mosquitoes, the female Anopheles mosquito picks up the blood and the parasite and transmits the disease to others. So this is his contribution, that the mosquito was causing malaria, and the contribution of Charles Leveran that the malaria parasite was existing in the blood. Both of them, by the way, got the Nobel Prize in the years to come. What is the burden of malaria? So as Dr. Amol rightly said, we need to think about fever, we need to think about war. This is a war against fever. So if you want to fight a war against your enemy, you need to know who the enemy is. You need to know where the enemy is. And you need to know what are the weak points of this enemy, because that's how you're going to fight a war against malaria. So that is what the epidemiology of malaria is all about. Who is this agent, who is getting affected, and how we can actually attack this virus, this parasite that is causing malaria, how we can actually attack the vector that is causing malaria, and how we can deal with this. So around 240 million, this is in 2020, incident cases of malaria that took place, around 6.2 lakh deaths of malaria. Now, majority of these cases, majority of these deaths, nearly 90%, almost more than 90%, takes place in Africa. India, as Dr. Amol rightly said, in case if you take Southeast Asia, India kind of rules that. And the majority of cases that we have in India are Vivex type of malaria. The total number of cases now we have, we can actually dream of eliminating malaria because the total number of cases that we have annually are less than 1 million cases. Just to put this into perspective, I want to tell you that at the time of independence, 1947, annually we used to have 75 million cases of malaria. Okay, so 75 million cases of malaria annually. Now we have come to less than 1 million cases annually. The total number of cases, as you see the graph over here, the total number of falciparum malaria cases or Vivex malaria cases, the total number of deaths due to malaria have dramatically come down. So this is something very good because we have very good medications now, and we have very good strategies to deal with malaria, but we need to make sure that we do it well and do not relax and do not allow the resurgence of malaria, do not allow the resurgence of resistant forms of the parasite, which will be very difficult to deal with because we don't have too many drugs that we have with us. I'm just sharing this small slide that I got from Dr. Kalpana Mahatme, who's leading the malaria war at the DHS in Goa. And I'm not going to the details of it because she'll explain more, but I want to highlight a few things. If you just look at 2020 and 21, the total number of cases of malaria have come down dramatically. World over, because of the COVID pandemic, the number of cases of malaria have actually increased. The number of deaths have increased. In fact, the WHO says almost 50% of the deaths, but due to the displacement that took place because of the COVID pandemic. But in Goa, because of the COVID pandemic, probably the number of cases in 2020 was 102. Total number of cases in 21 were 90. So less than around 100 cases of malaria annually. So number of cases of malaria has really dropped. If you look at all the cases from 2014 onwards, we see there was a dramatic drop. In 2014, it was 824 total cases of malaria annually. And in 21, it is around 90. So that drop has taken place. But look at it very carefully. If you see the split up of Plasmodium vivax and Plasmodium falciparum, the total number of falciparum cases have almost remained the same. 42 in 2014, 48 in 21. It's the number of vivax cases that we have managed to bring down to quite an extent. We have to, and I'm stressing on this, we have to learn from our history. We cannot, ignore malaria, because this is a war that we're fighting against this parasite. And the parasite is very smart. It's a war we're fighting against this mosquito, and the mosquito is very smart. In 1953, when we had these millions of cases of malaria taking place, the government of India launched what is called the National Malaria Control Program to bring down the prevalence to an extent that it's no longer a public health problem. 75 million cases annually, as I said. In 5 years itself, by just spraying DDT and giving chloroquine to those people who had malaria, they managed to bring down the prevalence to 2 million, 5 million to 2 million, a dramatic drop. They felt that if this is the rate that we are going, we can actually eradicate malaria. We can wipe out this parasite the way we are trying to wipe out smallpox, etc. We can wipe out this parasite as well. And they launched what is called the National Malaria Eradication Program. They were doing extremely well. In fact, in 1960s, 1964 or so, I think they've reached the total number of cases in India were around 1 lakh. So from 75 million to 1 lakh drop. So this is the level at which they managed to bring down the cases of malaria. But again, after this, the number of cases began to increase. The parasite began to get resistant to the drugs. The mosquito began to get resistant to the DDT that was being sprayed at that point of time. There was a lot of urbanization. The number of cases of falciparum malaria began to increase. The number of deaths were increasing. Somewhere in 1976 or so, the number of cases had increased to around 6 million or so or odd. And therefore, in 77, they had to launch what is called the modified plan of operation. The program kept changing. Currently, we have a program called the National Vector-Borne Disease Control Program. So it's not a program only for malaria. So we had programs for filaria, for malaria, for Kala-Azar. All these vector-borne diseases are clubbed together from 2004 onwards in a program that is called the National Vector-Borne Disease Control Program, which is now under the National Health Mission. So briefly, a little about the vectors. Vectors are these kind of organisms that take the agent or that's causing the disease from one person to the other. And there could be various vectors that could be there. There could be sandflies and louse and mites, etc. These are all vectors. So all these vector-borne diseases that are transmitted by these vectors come under this program. And among the vectors, mosquito is one of the vector. But a mosquito is not just one vector. There are many types of mosquitoes. The female Anopheles mosquito, and why we always stress on females, because the female Anopheles mosquito requires the blood in order to get the eggs matured, and therefore that's the reason why they go and suck the blood. The male mosquitoes are vegetarians, and see them in the garden. But the female Anopheles mosquito require the blood, and that's why they require the blood meal. And in the process of taking this, they end up transmitting the disease. There are other mosquitoes like the Culex mosquito, the Aedes causing dengue, Culex causing filaria, etc. So keep in mind, this is the Anopheles mosquito. It sits at an angle to the ground. So that's what you can kind of identify that's how you can identify the Anopheles mosquito. If you see the Aedes mosquito, it's very dark. It has these stripes, black and white stripes. So that is very characteristic of the Aedes mosquito. For any disease to occur, you require the agent, the host, and the environment. You require an organism that either a virus or a bacteria or a parasite, as in this case, to cause the disease. That is the agent. The host, like humans in this case, who would get the disease, and an environment that is conducive for the spread of the disease. When these three interact with each other, that is when disease occurs. So this is important for you to understand, because if you want to prevent malaria, it's not only attacking the agent, it's not only dealing with the host and improving the immunity or treating the host, it's also dealing with the environment. You have to tackle it on all three fronts if you have to deal with it appropriately. This is what happens. The infected mosquito bites the humans. It sends in the parasite. These parasites sometimes go and live in the liver, and especially in the vivax form, there is some stage called hypnozoids. And Dr. Chitralekha will tell you that you need to give certain drugs for treating hypnozoids. If you don't give those drugs for the treatment of hypnozoids, then you can have a relapse of malaria. So then these parasites go into the blood and then form the sexual forms, which are taken up by the next feeding mosquito, and the cycle continues, and the disease spreads from one place to the other. I put up this picture just for you to understand the environment in which these mosquitoes breed. This is a construction site, and you can see at construction sites, you have all these places where you have curing waters. This is a place like a swimming pool for the mosquitoes to breed. And you have multiple stories, so you have multiple levels wherein the mosquitoes can breed. At a construction sites, you also have laborers, and the laborers could get resistant forms of malaria from different parts of the country, from maybe Bihar, from Orissa, wherever. And so you have the agent coming from there, you have a vector that is breeding in this environment, and you have the host all around where people can get, who are susceptible to malaria, and that's how the disease spreads. The reason why we actually had a drop in the number of cases during the lockdown period of COVID is because we had decreased the construction activity, because we didn't have much of laborers around the place, as a result of which the cases had dropped. What we need to do is consolidate these gains that we have got during this COVID period and make sure that we keep the cases low. We have very good laws that actually ensure that all the laborers, everybody working in this construction site, will have them checked. So if we ensure that the agent is not there in them, then we can still make sure that we control the disease. So for controlling the disease, I don't want to get into details. It is vector control. It's always been the case. Vector control, take care of the mosquito, make sure the mosquito does not bite. Early diagnosis and prompt treatment. Don't sit at home if you have malaria. Get yourself on the treatment as soon as possible. Decrease the parasitemia. And behavior change communication. You need to educate people such that they change behavior. I put this picture up of a hand that says end malaria, because ending malaria is in our hands, and not in the hands of doctors alone. It's in the hands of people, the hands of policymakers. It's everyone put together, the hands of teachers, and in hands of healthcare workers, sanitary inspectors. Everyone put together have to fight against malaria. Malaria occurs in our backyard. It is not about talking about the government not doing enough for the garbage, etc. The breeding sites for malaria all around your house, even inside your house. If you look at this picture, it shows you all the sites wherein, around the pots, in places, some swimming pools and all these water collection around the place, broken bottles somewhere, coconut shells. This is where Anopheles mosquito breeds in clean water. And these clean water all around the place. What you need to do, the various strategies for dealing with it. So it's like physical, chemical, and biological methods. Physical, just try to do source reduction. We follow something, or advise people to do something called dry day. Once in 7 days, wipe out all these water collection sources all around your house. So go around. Sometimes you need to keep water around your place, but if you throw that water out once in 7 days, empty the can, and then you can fill it up again later on. So that is what we call dry day. It will break the cycle of the mosquito breeding, as a result of which we'll be able to deal with it. There are chemical methods like fogging. There are biological methods like putting these fish, and you can prevent the mosquito from biting you by using various kinds of oils, etc. And insecticide treated bed nets. The long lasting insecticide treated bed nets are something that is shown a lot of utility in dealing with malaria. These are again some other pictures that we see all around the place. Tires are notorious for the breeding of mosquitoes. Mosquitoes are somehow attracted to the black color, and tires collect water. Even if you try to empty the tires, it becomes very difficult. So if you see tires collected around your place, make sure that you keep them in a place where they're not in the rain, where water cannot collect in these tires, because that is a place that mosquitoes will breed. Anything like these, like coconut shells, etc. Even a small amount of water is enough for the mosquito to breed. What the theme is focusing this time is on innovation. We need to be innovative to deal with the parasite, because the parasite and the mosquito is innovating against us. So there are various innovative ways by which they're dealing with this. There are some genetic mosquitoes that people are, I don't know how good that is, but they're releasing genetic mosquitoes that the sterile male technique, and mosquitoes that breed and only the offsprings are only male mosquitoes, and such things are happening. They're using drones to reach out to areas for spreading insecticides to make sure they can kill the vector for malaria. Newer techniques of trying to deal with, develop these nets for malaria. Newer drugs are in study, newer diagnostic techniques. And also very recently, the WHO has launched, last year, in fact, the WHO launched a vaccine for malaria. In fact, they've launched this vaccine in Africa. It is meant for areas which has moderate to very high risk of malaria. It is given to children, and whatever we know from the information provided by the WHO, the RTS-AS01 vaccine is showing very good effect in actually definitely trying to prevent the severe forms of malaria. Now, any preventive trial takes a long time for the results to come, because you need to wait and watch and see what is the benefit of this vaccine. So we'll get to know much more about that in the future. But what I'm saying is, the picture is very, very bright. We have managed to deal with malaria to quite an extent, but we had also managed to deal with malaria in the past, and we had failed again because a parasite showed us who is superior. So we need to make sure that we don't repeat those mistakes. We need to make sure that we are very we treat malaria properly. So therefore, as doctors, all of us should know the basic treatment of malaria, which Dr. Chitralekha will talk about. We cannot give our own combinations, because that will lead to the resistance of the parasite against these medications, and we cannot afford it. It's not that we have too many medications, but the ACT combination that we have is a very good combination for reducing the parasitemia. So there is the national policy as far as drugs are concerned, we have to take care about for this. What India has also done, when the WHO has launched this whole campaign for elimination of malaria, as Dr. Amol was mentioning, India launched the National Framework for Malaria Elimination with an overall aim of 0 indigenous malaria cases in the country by 2030. And hopefully we will, just like in tuberculosis, they want to do it earlier, in malaria as well, we would want to do that earlier. This is the way forward. It's a goal that we want to make sure that there are no indigenous cases. Locally, there are no cases. We could have imported cases, but locally, there are no cases of malaria. We have managed to reduce what is called the annual parasite index to quite an extent, and reach that kind of elimination level, but we need to push for it and make sure that we eliminate and finally, hopefully, eradicate malaria. It requires, it's a joint effort. We need to put in, everyone has a role to play in this in order to fight against malaria. So thank you all for your patient listening. Over to the next speakers to be able to enlighten you about the rest about, and I'm happy to come back on prevention and epidemiology of malaria.
Thank you, Amit. The whole idea of having the preventive social medicine person speak was that we prevent 1 bite and save 9 lives, literally. We will now move on to the more clinical aspect of the topic. And I have with us a very young physician, Dr. Chitralekha Nayak, who many of you all know, but just for those who don't, Dr. Chitralekha Nayak has done her MBBS and MD from Goa Medical College, having passed with flying colors. She's been a recipient of the President's Award, having watched the Republic Day parade from the President's box. She's been a meritorious student through her academic career. Currently, she's practicing as a consultant physician at Healthway Hospitals, besides rendering her services in her native village of Marseille. She will be talking to us about adult problems in adults, and then we'll have a pediatrician talk. Over to you, Dr. Chitralekha. Please share screen. So I encourage all the delegates to try and put on their questions in the chat box, both here and on the Facebook. Those who are on Facebook Live, we have quite a few seeing the Facebook Live program also. And at the end of the symposium, we'll ask our questions to our experts. Thank you.
I think everyone can see my slides.
Yes, Chitralekha, yes. Please go ahead.
I will start my presentation. Yes. I think the talk is actually, the aim of the talk is to create a public awareness about malaria, but the participants are more doctors compared to the public. So my talk will be more on a simpler version, especially what we should be telling the patients and what public, the general population should be aware about malaria as far as the clinical features and the treatment is concerned. Now, this is just a theory which every one of us have learned right from our MBBS times. And of course, as far as Goa is concerned, the Goans are very well aware of that malaria is a very common disease. So whenever a patient comes with fever, they will go and they will only ask the lab to do a malarial parasite test and see whether they have got malaria or not. But we were very happy that the cases in the last 2 years were very less. But because as what Dr. Amit said, that of the construction activities are going to increase, the economic activities have come back after the COVID decrease in the COVID cases. We are likely to see cases in early end of May to June, and malaria cases we may see a surge. But of course, dengue is now a predominant vector-borne disease currently in Goa. So surprisingly, today I see one of the first falciparum cases of the season. So today I see a falciparum case, and surprisingly the patient is searching for the tablet and he's not getting the tablet. So what has happened, the problem is now is because the cases have come down, the production of the standard oral medications which are to be given for falciparum have also probably not been kept in the pharmacies. So I think the government or the DHS should be ensuring that these basic medications are available, because we may see a surge in June, July because of the construction activities and climate change. We all are aware that we have a predominant falciparum and vivax malaria predominant in Goa. Why we have to treat malaria and why we have to diagnose malaria early is because we have to not only prevent death, this is a curable disease. Mind you, this is a curable disease. If we treat it early, the patient recovers faster. And of course, we cannot, it will also prevent the transmission. Where we have a problem is whenever a laborer or a migrant person comes to a doctor and he says he has fever, doctor मुझे एक बुखार का injection दो, मैं घर जाता हूँ. They never go to check for malaria. They never go to a lab and do a simple malarial test, even after advising. And this is where we fall somewhere. Probably we may do certain things to bring awareness among the people who are involved in construction activities, the ones who are migrants, to go and at least get a test for malaria, because they get happy when a fever injection is given and they go home. So of course, we have to prevent the deaths. Also, we have to interrupt the transmission by detecting it early and treating early. As we all know, malaria has a very classical pattern of fever, and that pattern is a high-grade fever with chills and rigors. Rigors, the fever is with severe muscle contractions and teeth chattering. This fever is usually around 102 to 104 Fahrenheit, and it will continue. It will continue even with, if we don't give treatment, it will continue every 48 hours or every third day. It may be also continuous. So whenever a patient comes with a very high grade fever, it is our duty to advise the patients, or the public has to be aware and they have to go and ask for a malarial test. Also, the malaria is one disease which can present in any form. There may not be even fever. I had seen a patient who had come with a renal failure, kidney failure, and after investigation, suddenly the patient could not pass urine for around 2 to 3 days. And when we asked history, the patient had fever around 8 days back. When we checked for malaria, falciparum malaria was positive. So patients may have very subtle symptoms. Patients may only present with vomiting, only present with diarrhea. Sometimes the malaria can also present with cough and breathlessness. So it is important for us to know that malaria can mimic other infections. So along with malaria, we have to screen other diseases, and also we have to see whether the patient has a vector-borne disease or not. Now, the second thing which we should be aware, that sometimes malaria may not be picked up in the first stage. A patient comes to you with fever for 4 days and we do a test and malaria is negative. then we assume the patient is not having malaria, and then we start investigating for other causes. But even after 8 days, the patient is still continuing to have fever, and his fever is not going. It's a high-grade fever. It is our duty to repeat the malarial test at the height of the fever and see whether he's still having parasites or not. Sometimes the smear for malarial parasite initially may not pick up the parasite. So, of course, fever is the cardinal symptom, but we should be also aware that malaria can also present with other atypical symptoms. So, uncomplicated malaria patient will have fever with vomiting and mild jaundice, because finally the parasites are in the red blood cells. So because of the destruction of red blood cells, we may get a little bit of jaundice and also liver and spleen enlargement. Some patients complain of abdominal pain in the left side because of the spleen enlargement. When malaria is not treated adequately, or we have not diagnosed it, or if the parasite load is very high, then the patient may directly present with severe malaria. It's very common in falciparum malaria, but mind you, vivax, we have seen a lot of complicated vivax malaria cases also during my residency. So anemia, the patient can directly present with a low hemoglobin of 5, 4 because of the destruction of RBCs. The patient can directly present with a liver failure, kidney failure, low sugars, jaundice, low platelet count, and bleeding because of the derangement of clotting parameters. And sometimes the patient may directly come with drowsiness with a high-grade fever, and we don't know what it is. We admit the patient as encephalitis, but when we send a malarial test, it comes positive. So we have to prevent patients from going to this stage where patient lands in kidney failure, liver failure, cerebral malaria. As what I had told you earlier also, in other infections like dengue and COVID, here time is important. If that time is gone, then the patient's recovery is delayed, patient's prognosis is poor, and patient's mortality also increase. What are the symptoms of complicated malaria? Cerebral malaria presents with fits, that is convulsion, altered sensorium, inability to sit, breathing difficulties, severe anemia and jaundice, and dark production of urine because of the destruction of RBCs. Also, the patients can come with paralysis, retinal bleeding. Elderly patients, remember, elderly patients may not present with fever. They may come with decreased oral intake, low sodium, increase in the jaundice, decreased urine output, and we may start searching for all the possible causes in elderly, but we may forget to send a malarial test. Please remember, elderly may not give a fever response. They may not show increase in the temperature because of their immune dysregulation. So these are the complications of malaria, cerebral malaria, low sugar, acute respiratory distress syndrome, which we have also seen in COVID cases, where the patient lands on ventilator, patient becomes breathless, kidney failure, hematological abnormalities like low platelet count, low hemoglobin, and also what we commonly see is a mixed bacterial infection. Many times patients, even after taking malarial treatment, will continue to have fever. So during that time, it is our duty to also check for Salmonella typhi, and the bacteria which causes typhoid can also come with falciparum and other and vivax malaria, and patient can get a mixed bacterial infection. So there, if we give an additional antibiotic which works against Salmonella, will help and the patients will improve. The parasite, how we diagnose malaria, it is by simple smear. We have to just collect the blood of the patient and check for parasites in the blood. If it is not detected in the initial phase, and if we are suspecting clinically that the patient is continuing to have high-grade fever, then definitely it is worth repeating the malarial test again after 48 hours at the height of fever. There are a lot of kits available in the pharmacy, in the labs and hospitals, where patients can go and test for the malaria and see whether the rapid test, it is similar like COVID antigen test, where we take the blood and see whether the patient's vivax line or falciparum line in the kit comes positive. And with that, we can start the treatment. But negative falciparum kit doesn't mean the patient has no malaria, the patient has to go for a smear for malarial test, where pathologist will see the blood of the patient and see whether the parasites are in the RBCs or not. Also remember, sometimes this is for doctors, where many times patients recover and they continue to have fever, and then we do another Falcivex kit. The Falcivex kit can come positive for few weeks after the patient has recovered from malaria. So here, if we want to know whether the patient has failed or the treatment failure has happened, we have to repeat a smear for malarial parasite and see whether there are parasites still in the RBCs or not. Other things which can come positive is low hemoglobin, low platelet count, creatinine increase, deranged liver function, and deranged clotting parameters. What we give for what are the treatment regimen? The treatment regimen has not grossly changed from the guidelines which are given in 2014. We treat 5x malaria with chloroquine, but yes, where there are a lot of chloroquine resistant cases. So if the patient continues to have fever even after 48 hours of chloroquine, we should know that we should shift to artemisinin based therapy. Sometimes what happens is the Vivex may cause relapse because the hypnozoites go in the liver and get stored, and they may come back again with a relapse malaria. So it is our duty to give a primaquine preventive dose. We give primaquine for prevention of relapse of Vivex malaria, and the patient should be knowing that the course has to be for 14 days. We cannot give these patients, there are certain areas where the patients may have G6PD deficiency and we may not be knowing it. The patients may not be aware that they are G6PD deficient. So if the patient takes primaquine and after primaquine the platelet count drops, the patient's bilirubin shoots up, patient gets jaundice or a very dark colored urine, then remember we have to withhold primaquine and then restart it later after testing for G6PD deficiency. We cannot give primaquine in pregnant women. Uncomplicated falciparum malaria, we give artemisinin combination therapy, where usually here the artesunate with we cannot isolate. So what mistakes which we as doctors should not be doing is we should not be giving an isolated artesunate. We cannot give because the resistance, if we get resistance to artemisinin, it's a big problem because we have less drugs for malaria available. So always when we are giving artemisinin, we have to combine it with other drugs. The other drugs like mefloquine, sulfadoxine, pyrimethamine or lumefantrine. So except northeastern states, here we the usual guidelines is artemisinin with sulfadoxine, pyrimethamine or mefloquine, whereas northeastern states they prefer lumefantrine. Now also here we have to give one single dose of primaquine. Now in pregnancy, what they say is quinine in the first trimester. This is as per the guidelines which are given by the Ministry of Health and Family Welfare. And also the Vivex, of course, we can start with chloroquine, but usually malaria in pregnancy is a high risk disease. The patient preferably should be screened for any complications, and preferably, if you ask me, it is not an oral treatment, probably a IV treatment if the patient is going in complications would help a pregnant patient. Mixed infection, sometimes I have seen patients with falciparum and Vivex combination. So the duration of treatment has to be 14 days as far as primaquine is concerned. And we have to see whether this patient is having complications. If no complications, then the treatment would be same as uncomplicated falciparum malaria. Now, this is a basic advice to the public whenever they are taking an anti-malarial drug is they should not be taking the treatment on an empty stomach. If the patient, suppose the patient is taking chloroquine and he vomits the dose of chloroquine, he has to repeat the dose again which he vomited after an hour or so. The patient should be told to come back if he cannot tolerate oral feed. He is continuously vomiting, he is having complications, he's getting a visible jaundice or his urine output is dropping. He has to come within 48 hours for IV medications. The IV medications are readily available in all the hospitals, and once they start with IV artesunate, the patient immediately recovers. Of course, we should also be sure to see for concomitant illnesses. Like, for example, now another trend which I have seen in the last 2 years, patient comes with malaria with dengue. So if this patient combination comes, the patient has to be in hospital. He cannot be kept home, because we have to monitor his fluid intake. We have to monitor his platelet count. The platelet count can just drop drastically to 10,000, and patient also can go in fluid shift and breathlessness. When we say a patient has got treatment failure, that even if the patient, ideally the patient is said cured if he has no fever or no parasites till day 28. So till first month, we cannot say. So that if the patient improves after the chloroquine treatment and after 5 days the patient has no fever, we cannot say the patient is cured. The patient has to wait till 1 month to see if the patient's fever recurs or not. Then only we can say the patient's fever has cured. But sometimes what happens is, because of the drug resistance, or if inadequate treatment has been taken, or if the patient has vomited some of the doses of the tablets, then the patient can go into treatment failure. And especially this happens in falciparum cases. So many times what happens is, even after 48 hours of chloroquine or artesunate, the patient continues to have danger signs or fever on day 3. This is an early treatment failure. Late clinical failure is the patient will have fever or signs of danger signs from day 4 to day 20, that is somewhere at the end of the month. So it is important for doctors also to be aware that, Baba, this fever, the fever may come back probably because the drug resistance had happened. And the late parasitological failure, which may be present in many of the patients, and we are not testing it, is if the parasites still remain on day 28. So these type of patients will benefit with a proper primaquine dose, and maybe these patients are the ones who can transmit the disease because of the parasites. So the late parasitological failure is if the patients are having that, then this is these cases are the ones who are going to spread the illness. How we treat complicated malaria? With a parenteral anti-malarial artesunate, which is available. And once the patient can take orally, we have to shift that patient back to oral artesunate combination. The patient, we have to see whether his hemoglobin is okay or not. Sometimes blood transfusion may be required, platelet transfusion may be required. We have to see the patient's creatinine, liver function test, mixed infections, and of course, these patients, please, no aspirin, no painkillers, no brufen, no Meftal, no nimesulide, no nice tablet for such patients. I have seen one malaria patient bleeding to death because of the nice tablet which was taken over the counter by the patient. For this patient, for fever, it's only and only paracetamol, no other painkillers to be given for such type of for malaria cases, especially patients who are coming with a high-grade fever. So when we admit the patient, when the fever is not going despite treatment after 48 hours, complicated malaria, cerebral malaria, malaria with heart disease, malaria with dengue, malaria in elderly with a sodium problem, please admit the patient. Mixed dengue and malarial infection, also I personally feel patients should be going in the hospital early. We give chemoprophylaxis for travelers, migrant laborers, and especially for the people who are getting exposed to malaria in highly endemic areas are northeastern states, Odisha. If I think Dr. Amit will be better to tell you, will be best person to tell that although Goa has seen less cases in 2020-21, Chhattisgarh has seen in 12,000, 20,000 cases. Odisha is in thousands. So those are northeastern states are still harboring malarial cases. Jharkhand, lot of malaria, especially falciparum cases. So when we go to such endemic areas, especially where we see lot of cases, yes, it is worthwhile giving to those travelers a chloroquine or a mefloquine or a doxycycline prophylaxis till 4 weeks after they leave from that area. So thank you so much for calling me for this talk. I think this was a very gross talk on malaria, especially this is for public awareness. But yes, only 2 points we should be knowing is, please do not give Bukharka injection. Just you give Bukharka injection, but please advise the patient, ensure that they go to the health center and get their malarial test done. So, and the second point is, please make available artemisinin based combinations readily available in all pharmacies. Thank you so much.
Thank you, Chitralekha. Just for everybody's information, Chitralekha doesn't have power at home. She has taken the trouble of driving 12 kilometers away to another place just so that she can be with us here today. Really, hats off to you, Chitralekha. One, just a comment here is that you said you saw a falciparum patient. And on behalf of Dr. Kalpana, who I'm sure is going to take this up with everybody, it's a request that we all notify these patients from private sector, government sector, everywhere. In fact, even the lay public, if there is a malaria incidence in your neighborhood, please notify the health authorities so they can go back and do the surveillance and try and do root cause analysis and see who caused the transmission, what could be done locally to prevent it. Next, we have with us another young speaker, Dr. Siddhi Nevrekar. She's a young pediatrician from Ponda. She has done her schooling in Almeida High School and then GVM Ponda, and then has done her MBBS and diploma in child health from Goa Medical College. She's been a practicing consultant in pediatric care for the last decade. She has special interest in neonatology and infant care. I invite Dr. Siddhi to join us and share her screen and give us a roundabout what special things to be looking for in pediatric patients and what special areas are there of concern in pediatric patients as regards to malaria. Siddhi, can we have you join?
Can I share my screen?
Yes, yes, you are seen, Siddhi. Please share your screen if possible. Rohan, can you mute everybody other than Siddhi? Okay, I think I managed to mute you. Siddhi, can you go ahead with your slides?
Yeah.
Do you have slides or you want to talk extempore?
I have slides. You can see the slides?
Not yet. You have to share your screen.
Just a second. It's coming host disabled participant screen sharing.
Oh, Rohan, can you help with that? Make co-host. I'm making you co-host. I think, yes. That way you'll be able to share. Please try now. Yes. Yes, we can see.
Thank you for allowing me to be a part of this discussion. Malaria in children is quite common. I mean, when the adults in the family do get malaria, the children also do get malaria. Recently, of late, with COVID being a part of the pandemic, I don't think so that we have got a lot of cases of malaria, but dengue has been a part. We have seen many cases of dengue coming up. So, as we know, it's spread. It has been already discussed that it's spread by Anopheles female mosquito, and it is not a rare entity to see children getting affected by malaria. And what we see most commonly is that cerebral malaria is, if in case a child comes to you, but then cerebral malaria affection is more common as compared to adults. And children do remain sick for a long time. And if in case they remain sick, then the neurological outcome is quite poor. Now, when I say that how will a child present to you with symptoms of malaria? Now, what happens is adults can speak. They can tell you, okay, I'm feeling cold, I'm feeling feverish. Or they can tell you that my head is paining, I don't feel like eating. But the only sign that a child is going to give you is crying. It is up to the doctor to decipher it as to what. Their cry is the only thing that you have to decipher. Okay, now the fever, as Chitralekha mentioned to us, is high spikes Obviously it's like 104, 103. It's associated with chills and rigors. Chills are normally cannot be seen, but rigors can be seen, and many a times parents mistake them for convulsions. They are absolutely irritable. They have got poor appetite, and all these symptoms mimic that of flu or cold. And that's why it becomes very difficult for us to understand that whether the patient is suffering from malaria or dengue or some other symptoms. So the first and foremost thing, we ask them to get a test done, that is an SMP or ICT, that is Falsivex, which is done. Now, if you are lucky enough, the smear which is done comes positive, then bingo, you have hit the mark, and then you get a positive test and you have got your diagnosis. But for that you require a good pathologist or a good this to diagnose, because what happens is the children are not very cooperative. But what happens is, besides doing all these tests, you need to do the other tests also, because children are not always, they do not always come with one complaint. So you have to do the test, and if the fever doesn't go, then it's essential that you repeat do the other tests as well. That is your CBC, PCV, dengue, your RFTs, LFTs, maybe not at that point of time, maybe after a period of 3 days, and then you come back, unless you have a strong base saying that the child has got to an endemic area, which was wherein there was history of exposure to malaria. Okay. Now, next thing that you can go ahead is, if you're sure that you have got a diagnosis of malaria, wherein your SMP as well as your ICT has come positive, you have to decide whether I have got an uncomplicated symptomatic malarial case, wherein there is no laboratory or a clinical evidence, wherein or organ dysfunction, or whether it's a complicated one. Now, what do I mean by saying complicated one is, the child is impaired, has got an impaired consciousness, has prostration, has convulsion, has acidosis, hypoglycemia, anemia, renal impairment, jaundice, pulmonary edema, significant bleeding or shock, and hyperparasitemia. Basically, the child is very, very sick. That's what you can see. Okay, it means the child requires utmost care, or basically a PICU care. So once this categorization is done, your mode of treatment will change. Now, the basic treatment as far as uncomplicated Vivex malaria is concerned has been already told to us, and for that we are very well versed with it. We all doctors are well versed with it. A tabular form has been given to it, and the parents are explained to it by giving the tablets, wherein the base form of tab chloroquine is at 250, and tab primaquine with a base of 2.5 mg base, wherein the tab primaquine is given every day for 14 days regime to prevent the gametocytes and relapse. Whereas as far as tab chloroquine is concerned, it is self-explanatory on the tablet, on the tab, and you have to give the child according to the age wise. So not on the weight, it's based on the age. So this slide is self-explanatory over here. Also, for the ease of administration, the program has introduced 5 different group specific combination blister packs of the ACT, as well as the age group wise dose schedule for the same, and each color combi pack given age wise dose schedule treatment for falciparum uncomplicated cases. So this tab are given according to the age and the age-wise dosage, so that it becomes easy for the parents to follow it, and they are given the same, so that there is no confusions as and when they come to the OPD. Now, uncomplicated falciparum. When there is uncomplicated falciparum, as I have already mentioned, it's a artemisinin tablet combination therapy, which is given for 3 days. It's a strongly recommended high quality evidence. Artesunate, sulfadoxine, and pyrimethamine kit is available. And this is recommended by NDP as a first line treatment. Now, suppose sulfadoxine cannot be given, there are other therapies which can be given. So, which are as mentioned, artesunate can be given, artemether can be given, artemether can be given, or quinine can be given. Their dosages are available easily in the guidelines. If at all the parental dose of quinine is over, you can further give it in form of oral for 7 days along with doxycycline. Once doxycycline gets over, or it can be continued with clindamycin, or you can give ACT as described in the previous slide. Artesunate and artemether are high parasite removal rate. Lack of the adverse effects and absence of significant resistance has been also seen. Long-acting, persistent for weeks at subtherapeutic doses. They are sulfadoxine, lumefantrine, mefloquine, amlodipine, and they kill the residual parasite and protect against resistance. Now, what is the difference between adults and children? More so, what makes malaria in children different from adults from children? First and foremost, there is lower mortality as far as the children is concerned. We see hardly any mortality. Frequent seizures and more commonly neurocognitive sequelae are found in children. Higher rate of associated is seen in case of children. Lower rate of renal dysfunctions are seen in children. Though you cannot generalize relapse, but recurrence are more common in certain localities. But this can be generalized for both, as well as adults, as well as for kids. But it is found that in children, the relapse and recurrences are comparatively lesser. Mixed malaria, uncomplicated cases are treated using ACT, but it should not be used along with the sulfadoxine as per IMR guidelines. Now, what do we do? What is the form of treatment that we should utilize when they come for follow-up? Whenever a child comes for follow-up, it is very much essential that we assess them thoroughly. We should check for their cognition, their neurological examination, CNS examination has to be done thoroughly. Their GIT has to be examined, GIT in the form of any organomegaly. Their HB, PCV has to be checked. Also, we should check for their any mild motor or gross motor, fine motor milestones have to be checked. And we have to also see that their nutrition has been going on proper. In case any of this has been faltered, we have to advise the parents regarding the same. The iron content in the body has to be maintained properly. The calcium content in the body has to be maintained properly, and appropriate advice has to be given to the child. So, in a gist, you should not treat falciparum malaria as a single drug. ACT drugs remain the choice for falciparum. 3 days course is sufficient and it's always recommended. In any complicated condition, switch and complete the course, preferably ACT, even if in case you have given an injectable earlier. Radical cure of primaquine is important. Monitor vitals at all times and keep an alternative diagnosis in your mind always. Now, as far as chemoprophylaxis is concerned, most of the time, Up to 6 weeks, children can be given doxycycline above 8 years only. Below 8 years, there is no recommendations of doxycycline allowed. In case of stay of more than 6 weeks in endemic areas, there is no recommendations which are given for any form of drugs. Instead of that, they have asked for medicated bed nets or bed covers to be used, and that's it. So that can be taken. The key points to take home is sulfaroxine cannot be used in children less than 5 months. So you have to choose an alternate ACT. All mixed infections are to be treated with primaquine. Quinine can cause hypoglycemia, should be captured. Biovex, no more. And Dr. Amol already mentioned 25th April is World Malaria Day. We must report each and every case of malaria to health department. We must work together as one page and on one page and as a group together, and keep all the areas free of mosquito breeding sites, and keep Goa clean and safe. That's it. Thank you so much.
Thank you, Dr. Siddhi. I'm sure there are quite a few questions waiting for you at the end of the program. I again request the delegates to put questions both here in the chat box as well as in the Facebook. We have quite a few people watching on the Facebook Live also. If you noticed, a lot of discussion is about prophylaxis of malaria, and that's the real credit to Director of Health Services Goa, who have been doing such wonderful work. Interestingly, they are amongst only 15 states in the country which are eligible to be placed in elimination group for malaria. And the target is actually this year, and means 2022-23. We are privileged to have with us as the main chief guest for today's symposium, Dr. Kalpana Mahatme, who is the state project officer for vector-borne disease control program. If you noticed, a lot of the problems of malaria and dengue go hand in hand. If you can prevent malaria, you would also prevent dengue. You would also prevent the other vector-borne diseases. So that's why probably with a lot of wisdom, this is being run as a national vector-borne disease control program. And Dr. Mahatme has been doing yeoman work. She has a huge team. I was personally witness today to the fantastic work that is being done, was presented at the Institute Menezes Braganza Hall. Quite a few of the technicians especially have finished 3 decades of service and have been acclaimed across the country for their superb work. May I request Dr. Kalpana Mahatme to please enlighten us more about the work being done by Director of Health Services towards malaria elimination in Goa. Madam, are you?
Yeah.
Yes. Yeah.
Can you see me?
Yes, ma'am. We can see you.
Yeah.
Are you having any slides or something to show us?
No. I will just talk extempo.
So if you can
Thanks
just
for
move the camera a
light
little
behind
down.
you.
Okay.
Yes, now we can
Yes,
see you
it's better.
Yeah. See, before I go to the main elimination part, I would like to tell something. Can anybody unmute? Hello.
Yeah, please go ahead, ma'am.
Yeah, before I go to the elimination, I would like to stress on some of the points which Chitralekha and Dr. Chitralekha and Dr. Nevrekar has said, because I just want to put it straight before I go to the elimination. So first of all vector-borne disease, this is for all clinicians, all vector-borne diseases are notifiable disease since 1996. So I request all the clinicians, as she has just seen one case, falciparum, which needs to be notified, and to the nearest PHC or to NVBDCP DHS. Even they can mail to me. Email ID is nvbdcpgoa@gmail.com. This will help us in control of transmission. Second point which I got from both the this presentation is, which I need to put straight, is Goa is an endemic to malaria. Hence, patient with fever due to any cause has to be ruled out for malaria. So smear needs to be taken. Regarding medication for falciparum, kindly refer. I'm not, instead of referring to the pharmacy, kindly refer the patient to the nearest PHC or to DHS, because we have enough stock of falciparum, all the anti-malarials. And we have age-wise blister packs for falciparum malaria. So treatment is not a concern for us. So please refer all your cases in case the treatment is not available, and it will be better if you refer the cases to us, health center, instead of private, instead of pharmacy, so that we can, even if you don't notify it, we can get the number of cases. And now the third one is regarding smear negative in the first visit. Kindly repeat after third day. And my request is, instead of referring the patient, especially the laborers, to any lab, you can always do RDT. And if it's positive, you can always start the treatment. And then you can refer the patient to the nearest PHC for smear. Because what we are doing at DHS, for every RDT, we are taking a smear. Because smear is the golden diagnostic tool and not the RDT. That is one thing I wanted to put straight. And primaquine is the only drug acting on gametocytes. And so if you refer the patient to us, we are doing follow-up slides for that patient at 7-day, 14-day, and 28-day. So we know that the patient is nil parasitemia. We do not wait. So the follow-up is very important. And each and every case has a case investigation form is filled. And this is written. Follow-up is written. In Goa, according to guideline, it is just artesunate combination therapy with SP. Mefloquine was earlier used, but now it is just SP. And my request is kindly to some of the clinicians not to use artesunate alone, as already falciparum has gained resistance to chloroquine. And artesunate is the only tool in our hand, weapon in our hand to act against falciparum. And and one more thing is what Dr. Chitralekha said, that if the patient is goes into complication, so why wait for the complication? According to the new guidelines, if the fever doesn't subside within 24 hours, if the patient headache doesn't come down, if the patient still complains of headache on the second day of taking chloroquine, if there is a continuous vomiting, not able to retain any oral fluids, or there is signs of dehydration, the patient needs admission. Now each and every because Goa is in the elimination phase, because we have to maintain zero indigenous case as well as zero deaths. So we have to end, and I request all the renowned clinicians in private practice to please help us. This is what we want. We want it to be notified. We want that treatment has to be started immediately. And we also want that instead of waiting for the patient to go into complication, then admitting, please look into these 4 steps. If fever, headache, vomiting, not able to retain, please admit the patient. Or you can refer the patient to the nearest health center. This is what I wanted to tell. And no giving artesunate alone. And please stick to artesunate SP combination, because that is according to the guideline. And we have enough stock of blister packs, that is age-wise blister pack. In our health center, the treatment for falciparum is given by the field workers. So it is as easy because there is age-wise blister pack. So now I'll and malaria in Goa is a migrant malaria directly related to the influx from endemic state. Even a local indigenous case can be traced to a construction in its vicinity. The prevalent areas are Panji, Kandolim, Portalim, and Kasarwan and Madgaon. And I think Dr. Amit had mentioned about health cards. These health cards are mandatory as per Goa Public Health Act. And this has helped us in bringing down the malaria cases. If they are, and there is punitive action. So if a patient, if a laborer is found without health card at the construction site, the fine is about 10,000 per labor. So this we are following it very strictly. And malaria, Goa is among the 15 states, as you already said, because our API, that is annual parasite incidence, is less than 1 at the state as well as at the district level. So accordingly, the categorization is done by Government of India based on the API. There are various indicators like ABER, slight positivity rate, but they have taken categorization based on API. And further thing is our district wise, Bihar, our data is very, although people have, speakers before us have said that because of COVID, maybe the cases have come down. I'm not denying that. That could be one of the cause for reduction of cases. But then our workers are working very hard in the field, and each and every contractor is supposed to notify the laborers as soon as they come to the that construction site, and they are screened. And our district-wise API from 2017 onwards has come down from 0.42, and now in 2019 it has come to 0.17. At that time there was no COVID, but 2021 it has still come down. But I can as well, we can also put it as a query regarding the influx. But from 2017 to 2019, it has come down from API from 0.42 to 0.17. And out of our 34 health centers, 25 health centers have already achieved zero indigenous cases. That is 10 in the north and 15 in the south have achieved zero indigenous cases, except for 7 high-risk areas for malaria, that is Panji, Pororim, Kandolim, Chimbal, Shuolim, Madgaon, Kortalim. In this area, their constructions are in full swing, and but our workers are working very hard. They are on this site. They visit. They also supervise the anti-larval measures, because according to the Goa Public Health Act, the anti-larval measures have to, at the construction site, have to be undertaken by the contractor. They should have a pump. They should have a chemical which is being, and the anti-larval measures are supervised by our workers. And regarding the data of API, from 2017, the API has come down. Most of the states, in most of the PHCs, in case of South Goa, only 2 PHCs, that is Madgaon and Kortalim, shows API more than 1, not more than 1, but not 0, less than 1. That is Madgaon is 0.06 and Kortalim is 0.20. And also in north, there are 5, Panji, Kandolim, Kasarmane, Porurim and Perne, have to bring API to 0. The health center had to achieve 0 API, have major constructions in full swing. So that's why the cases, we are unable to get the cases down in these areas. Plus our sensitive zones. Our sensitive zones are the major construction site, migrant settlement area and peri-urban areas, tourism shacks, industrial units and fishing jetties. And we are focusing our concentration, focusing our efforts at these sites, because we know that our malaria in Goa is more of the migrant malaria. And the innovations which our DHS or NBPDCP or DHS has done is each PHC has its own micro plan and strategies, appropriate strategy for prevention and control malaria, along with stratification of malaria foci down to sub-center level is being done. And micro plan has line listing of all construction, abandoned construction, scrap yards, kulaghar, stone quarries, migrant settlement area, jetties and IDCs. And these are updated, and action plan is prepared accordingly. And there are the documents. Each health center has document. One of the document is a list of private practitioners, labs, private hospital in their jurisdiction. How many of the private are reporting and number of cases reported. So this is my again request to all private practitioners and labs to notify the cases. This will go, if we have your support, this will go a long way in achieving our target of elimination. And I would also like to tell you that there we have challenges. There is a hidden sea of asymptomatic malaria carriers among the laborers coming from high endemic areas, which are undiagnosed during the screening for health cards, resulting in transmission. What happens is when we do SMP or RDT, at least 50 parasite has to be there in the blood to be detected. Hence, we miss that. So, and then there is absence. Also, there is absence of any process documentation of mega projects in the initial state. for planned preventive strategies to be implemented. Especially in Kasarwane, we had a lot of cases because of the Ayush hospital. If we are able to know what mega projects are going to happen, we can plan accordingly. Even tracking and tracing of the labor is a very difficult task. As Goa is small, contractors move the worker from one construction from north to south. Even new areas of focus have developed. Earlier, labor along with their families used to reside at a construction site, and we could, while doing mandatory screening of the laborers, we were also screening the family members, even the children. But now they are staying in rented places, close in the peri-urban areas, close by villages, leading to new focus. And one more thing is being an epidemic prone disease, real-time reporting with complete address, details of the patients, especially from the private section, is still a challenge, which I hope will be cleared after this. This is what we wanted, so that we can work hand in hand and we can achieve, because what the state of Goa achieves is because the private and government works hand in hand. And one more thing, what we are doing is all imported cases, whichever are detected at the health center, they are sending the report immediately, real time to NVBDCP DHS. And we are sending it to the, we are cross notifying it to the concerned SPO of that respective state. So the transmission, he can take preventive action in his state, thereby the influx is coming from that state to us. The positivity will come down. That is what we are hoping. And we are doing some research study with NIMR. Whatever is our weakness, we are trying to gain, which will affect our target of achieving malaria elimination by 2022 to 2023. We have some research projects going on with NIMR, National Institute of Malaria Research, like study on asymptomatic or low density malaria parasite infection in the community and its transmission potential. What they are doing is they are taking the blood samples and checking it under PCR. So under PCR, even if 5 parasite is there, they can detect it, so that we can start the treatment immediately, and will be no transmission. Also, we are having something like community behavior and determinant in relation to malaria prevention and control, because we are using so much awareness, IECs we are doing, so much awareness, posters, all these things are doing. But still, although people are knowing what are the potential sites of breeding, what causes malaria, what are the breeding sites, but still we do find that the potential breeding sites are still being left out, and we are getting the vector breeding. So this will tell us what are the gaps, and we may what we need to be, they need to be plugged. And another research study which is in the pipeline is also with NIMR. All these projects are being funded by MERA, Malaria Elimination Research Analysis Wing of ICMR. So in this, one mobile app-based tool will be beneficial for real-time capturing and monitoring of malaria cases among migrant laborers in Goa state. So mobile app-based tool will be beneficial. So genotyping also, the parasite will be done, even drug resistance. In some of, like earlier speakers have already said, that there is drug resistance in some of the states. So we in Goa get influx from this endemic states, which are highly endemic. And we do not want any resistant to the anti-malarial to be reaching Goa. So in this app, what we are going to do is the contractor will be the point of implementation. The contractor of the study area will be trained regarding the installation and working of the app. The contractor will install the app in his workers as soon as they are brought from outside in their mobile phone, and immediately details will be available to me, that is State Program Officer and BBDCP, and in charges of the health center. Next day, a team from the health center and personnel from NIMR will visit the site, and the health center staff will take blood smear, while RDT and blood samples for PCR will be taken by the research study personnel to rule out any asymptomatic or low density carrier. In case the laborer is found malaria positive, Then NIMR and Goa University will conduct genome typing and check for drug resistance. These are the studies which will help us in control in our target of elimination of malaria from Goa. This is what I wanted to tell. What are the things? Thank you very much.
Thank you, madam. Thank you. We'll come back to you if you have some questions. But we've got quite a few questions, and some of them we can see in the chat box here itself. I request all the speakers to please show their video so we can see everybody in Facebook also. It gets streamed if you're put your video on. Siddhi and Chitralekha, could you please put your video also? And unmute yourself. So like we started in the same order, we'll take the questions. And if you saw, like just to sound repetitive, DHS have been doing such wonderful work in Goa that we are in the elimination phase of malaria in Goa. And probably when we go and travel out of Goa, we feel a little uncomfortable that we might catch the malaria and bring it back to Goa. And we might be the cause of the migrant malaria coming to Goa. Not just the tiger, the malaria is also migrant in Goa right now. So if we can have Amit talk about, how to prevent both the pharmacological methods and some, because Siddhi had touched upon some of the other methods, you can tell us what would a traveler do to avoid getting malaria when he's traveling, and when would tablets be useful?
Yeah, thanks, Amol. Very interesting question. I think I'd like to simplify this by saying A, B, C, D, and I hope you remember this. A is for awareness. I think the traveler needs to be aware about every case of fever could be malaria unless proved otherwise. So if he goes to an area, gets fever, get tested for malaria. Time is crucial. You need to bring down the parasitemia if you want to deal with malaria. B is bite prevention. So they need to make sure they wear long sleeves, especially if somebody is going into some forest trekking and all these kind of things. Somebody is coming, go to a construction site. So these are the places where malaria prevalence or incidence could be much higher. If you go to a coastal belt where there is some construction going on, they could be at risk of getting malaria. So wearing long sleeves if possible, that you're coming to a tourist place, long sleeves may not be. Wearing repellents like DEET, that could be there. So prevent the mosquito bite. C is chemoprophylaxis. If they're here for long, I think the speakers have spoken about mefloquine or doxycycline. They can choose from that. For children, it becomes a problem, but then mefloquine or doxycycline could be the chemoprophylaxis for them. And D is diagnosis. So get the diagnosis done as soon as the cases, you suspect the cases. So you can even do a rapid test to make that diagnosis. So they're aware of that. I think that's one way forward. Towards for the laborers, the main problem of malaria in Goa, as Madam rightly said, is a migrant form of malaria. So for laborers, they're not going to listen to ABCD and all that kind of stuff. They won't be motivated on their own. So it has to be done from top down kind of a thing. It has to be enforced. And that's why we have a law that enforces this. Now, the construction workers need to be time and again. So this is what behavior change communication is all about. We want them to feel connected to this. They should feel responsible that, okay, there is a laborer. I need to make sure that I will ensure that this place is going to remain free of malaria. I will ensure that my laborers are going to get the card and going to get tested. I will make sure they're not going to, they're going to get motivated to do that, and they're going to get motivated to prevent the spread of malaria. If that happens, I think we are on the right track towards elimination of malaria.
Thanks, Amit, for that ABCD that you gave us. Coming to Chitralekha, you told us very nicely about the methods of testing and when testing is really indicated. But having diagnosed malaria, once you have prescribed the medicines, what specific, I think you touched upon this, but I just want you to highlight it again. What specific precautions should the patient take while taking these drugs?
The malarial drugs are very important, and we have to take them in time, and the patient has to tolerate those tablets, especially chloroquine, which is known to cause a lot of nausea, a lot of vomiting. So, and we have to take in a gulp of, so the patient chloroquine doses, he has to take 4 tablets at a time. That's the first dose is 4 tablets at a time. So when the patient has to take those tablets, the patient is likely to vomit the first dose. The loading dose itself, the patient can vomit. So usually we prescribe, because they come with vomiting, we usually prescribe anti-emetics, the medicines which can reduce the acidity. But when the patient, when he has to tolerate the first dose. This is a summary. So usually what the books have mentioned is the first tablet the patient has to take in front of the doctor or in the health center or in the hospital, and once he has to wait for 1 hour and then go home. But because many patients are seen at OPD level, we prescribe and the patient takes it at home. So when the patient has to be told that you take the tablet, see that you don't get vomiting, but by chance if you vomit the tablet, then repeat the same dose after around 2 to 3 hours. And if he vomits that also dose, the patient has to come back to the hospital and take the IV medications, because if the patient cannot tolerate the first dose, likely that this patient is going to go in complications soon. Second point is the preventive, the chemoprophylaxis. The patient takes the anti-malarial, the basic chloroquine or artesunate tablet, but they forget to take the primaquine prevention tablet. Also, the doctors sometimes forget to give the primaquine prevention tablet. Sometimes primaquine initially we don't give because of the low platelet count. Primaquine is known to drop the platelet count, but later the doctor should be aware that yes, the patient has to receive primaquine soon once the patient recovers from the illness. So that duration the patient has to know and has to complete the course for 14 days. The third point which the patients should be knowing is not to take the over-the-counter painkillers, because the malaria itself can cause other renal and liver combinations, especially when the fever doesn't go. The common public start taking the other painkillers, Combiflam and other type of painkillers to suppress the fever. So that itself worsens the malaria, because painkillers are known to drop the platelet count and other hematological parameters. So main thing is the patient has to tolerate the tablet, and if the fever is not going within 48 hours, patient has to get admitted. If the clinicians have a slightest doubt that the patient, for example, if the patient comes with fever of 8 days, it is known that the patient will have complications. So why this fever of 8 days patient is to be treated at home? Rather, you give IV artesunate in some nearest health center or in hospital. Make him aware. Once the patient is taking orally, shift to an artesunate oral-based therapy and send the patient.
Thank you, Chitralekha, for emphasizing on all these points.
Amol,
Yes,
I would like to add one thing is the medicine can be taken on full stomach, and our health centers, we are doing the same thing, and we have not got any this complication. So that could be given to the, because that helps. If the chloroquine is given on a full stomach, it doesn't cause vomiting. As much vomiting, yes, she said so. Siddhi, if I can come to you and ask the question. See, in adults, at least it's quite, means they come with the complaints of fever and they're able to tell what's really happening to them. But in pediatrics, and that's one of the reasons why many of us, even doctors, are scared of pediatric patients, is because they can't really tell you what's happening and relate the history. So what would you look for? What would you advise parents to look for, and when would be they, suspicious that this could be malaria?
First and foremost, the child is going to be lethargic. There will be high-grade fever with rigors. Then, like one of the things is travel history, if at all, contact history. One would be thing, and probably high-grade fever and lethargy would be one of the two things with which can tell the parent that okay, my child is not well, not eating well. That could make the parent get the child to the doctor, and based on that, amongst the other, on examination, we might find some findings, like besides UITI. If in case there is no UITI, no other system involved, we could directly go in and do SMP or an ICT, which can prove. So that would be the the main points which can give a hint to us. So high-grade fever with chills and rigors, we have one throat, UTI, pneumonia, and malaria. These are the four things which come to your mind first. So
thank you, Dr. Siddhi. Madam Kalpana, we spoke so much about migrant laborers for construction, but Goa being a state that is always labor deficit, we are also importing workers in industrial estates. Even in our own homes, many of the times maids are employed through agencies. So is there any role to test them when they arrive? Is such health cards, I'm sure some mechanism is there to monitor them also?
actually in case of this industrial estate, there is no health card mandate, but we are screening each and every laborer coming. Or in case of maids staying, it is our duty to get them screened if they are from outside the state. So that would also help, because what has happened, that is what we are keep telling the people, because now that as per labor laws, the family cannot stay at the construction site. When they were staying at the construction site, it was easier for us to screen them, all of them at one go. But now they are staying, since they are not allowed, they are staying in our neighborhood, in our rented premises. So if the person who has rented, he may be a local person who has rented his premises to the laborer's family, so he can always inform the local health center. And our people, they need not come to the PHC at all. Our health workers will go to their houses and screen them. In that way, we can prevent transmission. Because when they were at a construction site, we have seen that when the laborer is positive, his wife and children were also positive, some were even asymptomatic. So I think that community also, role of community also plays very.
Hello?
It can bite anyone.
We missed some part of it, madam. Can you just repeat the end? Oh, I think we have lost madam's internet connection there. Coming back to Dr. Chitralekha, there was this question about, G6PD deficiency causing drug side effects. So is there a role for screening G6PD for all people, or how do we go about that?
See, it is not mandatory that every patient has to screen for G6PD deficiency. So many of us may be having that, but I would not advise patients to spend money on G6PD deficiency to take a malarial tablet. So they will. The clear-cut indication is if the patient has G6PD deficiency, after first dose of Primaquine, the patient is going to pass dark amount of urine. Other thing is, especially patients who in malaria, they are known to, and if we test also G6PD deficiency when the patient has malaria, it may come false negative. Many times G6PD deficiency, when there is acute hemolysis, the deficiency report comes negative. So we have to check it if we are checking it after 2 to 3 weeks. If we are giving, so such patients have severe anemia or hemolysis, lot of hemolysis and jaundice in an active malarial patient. First of all, this patient is not an uncomplicated patient, this is a complicated patient. So this patient will go for an IV medication. Now, once the IV medications are over, we are supposed to shift, we have to give a preventive dose, it's Primaquine. So then once the hemolysis settles, then the patient we can give Primaquine, or when the parameters improve. Now, if the patient during that time has a concomitant G6PD deficiency, then it will be a problem for the patient. So I would say not everyone should require. It is how we test is, there are 2 types of tests, qualitative, quantitative, and we see for the enzyme levels, and then we grade the G6PD deficiency. But a normal, because so many of cases we are seeing, we should not be advising G6PD for everyone. The indirect indication of a G6PD would be is after we advise a Primaquine, and after Primaquine the patient is landing in anemia, hemolysis, and a renal issue or a hemoglobinuria, then probably we should be suspecting G6PD and stop Primaquine temporarily, and then later on decide whether the patient requires a proper Primaquine dose on.
Yeah. Thank you, Dr. Chitralekha. We have some.
I have a question to you. For how long should we stop Primaquine before restarting it?
At least for 1 or 2, because the hemolysis takes, at least in a malaria, hemolysis to recover from a severe illness, we require at least 1 or 2 weeks for that to recover, especially the platelet count. So I think we should wait for 1 or 2 weeks and then start the Primaquine, especially in complicated cases. Okay. The other alternative, which because Primaquine is the only thing which prevents relapse, yes, there is nothing else which acts on gametocytes. We have to give Primaquine, unfortunately, to Vivex for some time and then.
Okay.
But don't give it when the patient has low platelet count or hemolysis, because then it is very difficult, because if the patient worsens, then we don't know whether the patient has worsened because we have given Primaquine, or it is because it per se the complicated malaria has pushed him into these complications.
Thank you, Chitralekha. We can see in the chat box Dr. Vijaya Nayak trying to ask a question and not completing. Doctor, can you unmute yourself and ask the question with more clarity? Something about every malaria patient needs follow-up by, you've not completed that. Dr. Vijaya Nayak, are you there?
Doctor,
Yes,
can you hear me?
Yes. Can you put on your video also and ask the question?
Yeah, doctor. My only one question was there that since I work under DHS and health center, we have observed that there are many patients we get like laborers, mostly malaria detected, and when we give them chloroquine treatment for 3 days, after that chloroquine treatment they feel better, their fever is subsiding. Then what they do is they take 2-3 days Primaquine and they'll stop it, and these are the patients we get they relapse. So it is we are able to trace these patients, the laborers who are not taking the Primaquine properly, because our field workers go and on the field, or we even call the patients for follow-up flights in our PHC. So whether I wanted to know like how about is going about with the private patients, whether they do come for follow-up slides or not, and whether how the treating doctor come to know whether the patient has taken the Primaquine at home.
See, as far as what I advise patients is, once a malaria case comes, once the fever goes, the patient has to follow up after 8 days for a checkup. Just tell them that we want to just examine you after 8 days and come for follow-up. They come for follow-up. You may examine, you may ask for blood test, you may not ask for blood test. But at least when they follow up, we know that the patient has taken at least 50 or 60% of the medications. That is one. Second thing is, see, in private, especially when malaria cases now, private sector usually what we can say the migrants, the laborers usually do not land in private hospital. They usually will go to a nearest health center for the treatment because of the cost purposes. Now, even if suppose they land in a private clinic or a private hospital, it's a duty of the doctor to call them after 8 days. Why to call them after 8 days? To see for compliance, to see whether they are going in complications, and to see whether they have another thing, whether they are tolerating Primaquine, whether they are getting complications because of the Primaquine, because many of them are from the Chhattisgarh area. They may be having G6PD deficiency or any other hemolytic illness also. So it is our duty to see that they come for follow-up. The other thing, it may be also you can do it, and maybe at DHS level or private sector also, to see whether the smear for malarial parasite has come negative after the treatment, because that will also tell whether the parasite load has come down or not, whether the patient is having still a low parasite load in the body. So that will also, like for example, I had got a patient 2 years back where the patient received the full artesunate course. The full artesunate course, we gave IV medications, we shifted to oral artemisinin therapy, and after I tested it for a smear for malarial parasite. After around 1 month, the patient had still smear for malaria test positive. So such cases probably we may detect if we call them and we do a repeat smear for malaria parasite after around probably 15 days and see whether they are still harboring parasites or not. So that will also give us indication whether the patient is having resistance to treatment or not.
Thanks, Chitralekha. I think Madam has made it abundantly clear that, besides you calling the patient, you should also inform the Director of Health Services, because they have their own very beautiful setup in which they are able to, trace these patients, find out where, because currently there is no indigenous malaria in Goa. It is all coming from some source. And if we go and tackle the source and do source control, we might prevent the spread. It is a little difficult sometimes to do follow-up care in private, because many times patients are floating population, don't really come back to us. So very important that we not only tell the patient that you need to come back, but also inform the health authorities. I think Madam wants to add something to that. Madam, you can unmute yourself. Just unmute yourself, ma'am.
Okay.
Yes.
Can you hear me?
Yes, ma'am.
What I want to add to what Dr. Chitralekha has said is our follow-up is very strict. So in case of like if the patient is from Jharkhand, that is what she's talking about. If it's not, I believe he's a laborer. So there is no, because sometimes laborer prefer to go to private. So we should actually, if you treat the patient at the first go, but at least send the patient to the health center nearest for the follow-up. Because unless we do the smear, we cannot trust that compliance, because we have to see that there is nil parasitemia. Just listening to, because if you ask the laborers, आपने medicine लिया है, खत्म क्या? They will say yes. So you cannot trust. So that is why the follow-up and follow-up smear is very important. So in case of private, if you treat the patient, please notify the patient to us and send the patient for follow-up to us, because we are not just asking him compliance, but we are doing the smear examination and testing the parasitemia, nil parasitemia. That is what is my this advice.
Yeah, and
as a
continuing with
manager.
the innovations, this year's theme innovations. I think the NVB CDP is also tying up with this research center, and there is proposals to use the the latest molecular techniques, where not just the smear, even the smallest amount of parasite. If I heard it right today, Madam said even 5 parasites in one microliter
PCR.
could be detected. Yes.
That is under PCR.
Yeah, so under the polymerase chain reaction, they could do so. Even the testing methods are going to get updated. Surely these innovations will help us. I think we are running short of time. It's really been a brilliant 1.5 hours plus now. If there are any more questions, quickly, if we can have anybody put up in the chat. Else, I hand over the proceedings to Dr. Anand Dalvi. So Karji Goa is asking, does fogging really help in malaria and dengue?
I'll answer that for him.
Yes, ma'am.
Fogging is an anti-adult method. So it will only knock down the adult infected mosquito. Because whenever there is a case, especially a malaria case, we do fogging immediately in that area. If it is a dengue case, then we are not doing every day, because it comes in clusters. One case today, tomorrow, 2 more cases. So every day doing it is also not good for the health of the people, because of the chemical used. But many times we are getting requests from the public for fogging because of nuisance of mosquitoes. So that should be avoided at all cost, because if we start using indiscriminately this fogging method, then the parasite, that the vector will gain resistance to the chemicals which we are using, and then we will have to go for stronger chemicals which will have bad effect on the health of the people. So my request to the community, if they are this on the line, that do not fogging is only to whenever there is a case, and that we do without telling also. Each and every case, there's a malaria case, we do fogging, but asking request for fogging for mosquito menace has to be avoided. We have to take care of the breeding, like what Dr. Amit has told, that we have to take care that once a week we have to go around our houses, because there are so many unwanted articles stored there. Coconut shells, broken bottles, plastic cups, all these if they have water, they lead to breeding. So if we take care of our surroundings, then there will not be any menace of mosquito. And this, most of the times, this when a fogging request comes, it is mostly for nuisance mosquito, because of garbage collection. There is mosquitoes. So these are nuisance mosquitoes, not causing malaria. But then sometimes we do it fogging, which is not very good.
Thank you, madam. Can I request Dr. Anand Dalvi to please take over the proceedings? Anand, are you there?
Yes, thank you so much, Dr. Amol. It's a privilege to have been asked to propose the vote of thanks on this occasion. On behalf of the Executive Committee of Indian Medical Association Tiswadi branch, I must mention our deep sense of appreciation and gratitude towards all the guest speakers for today: Dr. Amit Dias, Dr. Kalpana Mahatme, Dr. Siddhi Nevrekar, and Dr. Chitralekha Nayak, for sharing with us their experience and expertise. The topic was understanding malaria, and we have definitely benefited from all the knowledge they've shared with us. I want to express my sincere thanks to the one and only Dr. Amol Mahaldar for coordinating and for moderating the program today. We would also like to acknowledge our gratitude to Rohan Nayak, our IT expert, for handling all the technicalities in organizing this webinar. Finally, a big thank you to all our members of IMA, all other doctors who have logged in from Goa, and the general public for attending today's webinar and making this program a success. We will meet soon for yet another webinar. But until then, from all of us here, from the entire executive committee of IMA Tiswadi, goodbye, good night, and thank you so much.
Thank you.
Thank you. Good night.